Good afternoon, everyone. Thank you all for joining us. My name is Matt Ewalt. I serve the Texas Tribune as Senior Director of Events and Live Journalism. Welcome to those joining us in person here in Tyler and online for today's discussion, titled How Rural Texas Communities Are Solving Healthcare Challenges. With small-town hospitals closing across Texas, many communities are rethinking their approach to healthcare. Today, we want to look at how communities like Tyler are taking on these healthcare challenges, what is happening on the state level to support these efforts, and how the future of healthcare will look in rural Texas. We're joined today by Kirk Calhoun, MD, President of University of Texas at Tyler, Christina Childress, Senior Public Health Official and Administrator of Angelina County and City's Health District, and Doug Curran, MD, Chief Medical Officer at East Texas Community Clinic. Our moderator is Tribune East Texas reporter Jess Huff. We also want to thank our host today, Tyler Junior College, and I'd like to ask Tyler Junior College President Dr. Juan Mejia to offer a few words of welcome. Dr. Mejia.
Thank you, Matt, so very much, and good afternoon to each and every one of you. It is indeed a great day of celebration when the leadership from our communities come together for the betterment of those who we serve. It truly is. It is an exciting day to have the Texas Tribune here. Can we get a round of applause for them? They have done a masterful job of convening a stellar panel of speakers here. And so thank you again. We know that we're all going to be the better. Jess, you're going to do outstanding as always. It's always good to see you. And I would be remiss if I didn't recognize my friend and colleague who just a couple of days ago announced his retirement as president of the University of Texas at Tyler. With a round of applause for Dr. Kirk Calhoun, please. Dr. Calhoun, in addition to being a great colleague, is a dear friend and has truly done great for our communities, 22 years of service, and it is an honor to have had the privilege of working with them. So today is where care intersects with strategy, and we're fortunate that you are here so that we can continue to do better and really lead the way as a state and as a country in what we do in the care for others. So whether it is from the good book of doing good for others, of taking care of those who are sick, or the concept of the broken femur that was treated and healed and what we can do, this is the opportunity for healthcare to come alive. We know that healthcare is important for economic development, for regional prosperity. More important, it's important because it's who we are as humans. It brings us back to humanity. I want to thank the college's cabinet for being here. All the college's cabinet from TJC is here. Thank you all for making time as well. And to the many leaders who are here, what an honor. We're going to have a great day. We're all going to learn a lot and really convey how important it is to identify challenges and solutions as well. Welcome again. Let's have a great event.
So today's program will run an hour with 45 minutes for conversation and 15 minutes for your questions. Here in Tyler, we have mics for our in-person audience, and our virtual audience, those joining from around the state, can also submit questions online at our Q&A portal, texastribune.org/ask. We are grateful for the support of our sponsors. Our major sponsors are AARP Texas, Christus Health, and Methodist Healthcare Ministries of South Texas. Our supporting sponsor is Texas Rural Health Association, and our foundation sponsors are TLL Temple Foundation and the Ben and Mady Fish Foundation. Though corporate sponsors and donors underwrite this event, they play no role in determining the content, speakers, or line of questioning. On behalf of my Tribune colleagues, I also want to thank all those throughout the state of Texas who support the impactful journalism of the Tribune, including those who have become members. To learn more and to become a member, visit texastribune.org/support. And now let's get to know our panel. Kirk Calhoun serves as president of the University of Texas at Tyler and chairman of the UT Health East Texas Board of Directors. In 2020, UT Tyler administratively merged with the University of Texas Health Science Center at Tyler, combining the academic and health operations to form a new comprehensive university serving East Texas. The new UT Tyler School of Medicine, which enrolled its first class of students in 2023, is the first medical school in East Texas, and from 2002 to 2020, Calhoun served as president of UT Health Science Center at Tyler, during which time the campus grew significantly. He is a professor of medicine and has an MD from the University of Kansas. Christina Childress, currently serving as a senior public health official in Angelina County, is committed to ensuring compliance, strategic planning, and effective public health services. She brings 16 years of experience in emergency preparedness, health promotion, community education, and leadership, with a focus on evidence-based approaches to drive the development, implementation, and improvement of programs and services. Doug Curran, Chief Medical Officer at East Texas Community Clinic, has practiced family medicine for over 40 years. He is currently working to obtain federally qualified healthcare status for East Texas Community Clinic to fill the gaps of medical care in East Texas, and working with UT Northeast in establishing a family medicine residency program in Athens, Texas. Our moderator today, Jess Huff, joined the Tribune in 2023 and is based in Lufkin. She grew up in Utah and has also lived in Arizona and the Netherlands. Her latest adventure brought her to East Texas, where she worked for the Lufkin Daily News, leading the publication to numerous awards for investigative reporting in the region. I thank our panel and our audience for being here today, and with that, I turn the program over to Jess.
Hey, y'all. Is this going? Okay. Yeah, writing investigative news stories is a lot easier than asking a panel of individuals questions, so deal with me while I sweat a little, okay? Well, so this event, I think, is a perfect way for us to show the world what rural healthcare looks like in East Texas. This is something that we have seen communities struggle with across the nation, but I think East Texas is doing something unique. So my first question I'd like to lodge at the panel is, could you describe to me from your own communities what you have seen rural healthcare look like in your experience? Maybe Dr. Calhoun, could you start with that?
Sure. Thank you so much, Jess. It's a real pleasure to be here. And of course, to be at TJC and with Juan, my very wonderful friend. Both institutions have significant resources invested in training healthcare professionals. And I dare say we actually partner in doing that. We do it well together. We interact with each other, and we're very supportive of one another in producing the healthcare professionals that this region of the state needs. I guess when I came to Tyler 22 years ago from the Dallas Metroplex, I was most struck with the fact that healthcare right here in Tyler, Texas, is quite different than what exists in some of the smaller, more rural communities that go throughout East Texas. I mean, we're very blessed with 3 hospitals here. 2 hospitals have significant trauma services, for example. Both hospitals do a lot of outreach throughout Northeast Texas and so forth, and have clinics and so forth. But what we have here in Tyler is exceedingly special and quite unique, and affords our community really excellent access to medical care. On the other hand, as you go out into some of our more rural communities, there's a lack of OB services or a lack of mental health services in those communities. I was surprised to see data about the traffic fatalities, and that the traffic fatalities per capita in Northeast Texas, that number is higher than the fatalities in the big urban areas of the state because they happen out on rural highways. And people can't get there in that golden hour, can't get the services they need when necessary. So these are some of the issues that I think I've been thinking about a lot. Those efforts went into the development of the new medical school and trying to incorporate this commitment to serving the more rural elements of the state through how we expose and educate our medical students.
Absolutely. Ms. Childress, I'm sure that you have more to add.
Yes, absolutely. And thank you all so much for being here, and thank you for the opportunity to be here to speak with you all. So for Angelina County, I think that it is very similar. I was a military kid, so I grew up in a couple of cities, but also went to undergrad in a rural area. And so coming to East Texas, I learned to adapt really to any situation or where I'm at. So it looked different, but what struck me was the people, the hospitality, the community that comes around one another and helps each other, the collaboration, the opportunity that's there. There's so many great nonprofits, there's so many great organizations that are doing the work, who are walking alongside those folks in their communities and just making it happen. And I would say from a population, from the side of the population, we're looking at, child poverty. We're looking at just the access, those challenges with access, whether it be transportation. Some of the studies that we've done at the health district, we've looked at health equity and health disparities and childcare. There's not a lot of access to childcare for folks to get back into the workforce, those things, right? But it takes, regular folks on the ground, knocking on doors or speaking at churches, and just listening to one another to figure out how we can help, how we can strategize, and how we can mobilize to move forward.
Absolutely.
Yeah. Also appreciate the opportunity to speak with everybody today. I think I have done this for 44 years and have, delivered babies, done full scope family medicine, and loved every minute of it. My patients are my friends. I used to, my white coat had more makeup on it than anything, from the hugs you get from the patients that you become such good friends with. And it's been a fabulous ride. And I think if I could get these young doctors to understand that, they might want to come to East Texas and practice medicine. But the reality is that 22% of the graduates will be coming to rural areas. The other 78% will go to the inner city or to the city areas, to the metroplexes and so forth. So that's the reality of where we are today. And trying to change that is part of what our medical school here in this region is trying to do, is to look at, okay, what are those little features that allow us to capture that individual that's going to hang around in East Texas and practice medicine. And there are some distinct features of those individuals. And a lot of it has to do with kind of how they came up. I grew up in a small town in northwest Arkansas. And to show you, I hate to do this, but to show you how old I am, Sam Walton ran the Ben Franklin store on the square in Bentonville when I was growing up. So, I've been around a while and got a little cobweb. But I lived in a small town, population 648. So when I moved to Athens, a population of about 18,000, I moved to a metroplex compared to where I was. And we started a family medicine group there, I and two other docs. And that now has about 19 practicing physicians and nurse practitioners, PAs. And I'm just really proud of that, by the way. I think it's amazing that we were able to do that and got that going and have continued to deliver babies in Athens. And then we started this residency program to try and teach young docs how to practice. And we know that if you train in rural areas, you're going to stay within 200 miles of where you trained. Odds are real good for that. I trained at John Peter Smith in Fort Worth, Southwestern Medical School's residency program, and I practiced in Athens, Texas for 44 years. It's about 120 miles from there. So it worked for me. And I think it works for our residents. Our first 4 residents graduate this summer. 3 of them are hanging around in the area. Actually, 2 right now. One of them's doing a fellowship in obstetrics in L.A., and then she's keeping her house, though. She bought a house. She's going to come back because she wants to work for us at the clinic at the Federal Qualified Health Center so we can take care of these people. And I think those kind of relationship building and the things that we're trying to do with the medical school, get students out, get them on ambulance services, get them out in the field. They're going to be coming to our Federally Qualified Health Center, and I'm sure others across the area. And as they build relationships, you'll see, I think, a lot of those things mature to the point that they're going to want to go back there. They've got a friend there. They got somebody there they can relate to. And that's what you got to have. And you also have to attract the couple. You know, I've interviewed lots of doctors, and if the spouse is not happy, they're not coming to rural Texas. That's all there is to it. You got to be sure you got all those things together to make living there what life is about.
Absolutely. And I think, you know, in speaking about staffing, we would be remiss if we didn't also discuss the impact of the nursing shortage. That, I mean, we've seen this nationwide. We know it's a problem statewide. What does this look like in East Texas, and why are we seeing these issues?
Well, what I think we've realized, and we have one of the largest nursing schools in the state, and TJC has a very aggressive and a well put together nursing program also, is that opportunities for nurses, those opportunities have exploded. There's so many realms that they can pursue. And as we try to make sure that we adequately staff our hospitals and our clinics and our physician offices, you know, there are insurance companies hiring them, there are public health districts hiring nurses and so forth. So we really have to gear up and produce more nurses and more qualified nurses in some particular areas. For example, you go these days to get a GI procedure or something like that, you're much more likely to get your anesthesia from a CRNA, a certified registered nurse anesthetist. And we didn't have a program here. You know, we're starting a program here. We're starting a flight nursing program because nurses go around and fly in helicopters and need that additional training. And then there's doctors of nursing practice. And probably we'll produce as many doctors as we can possibly afford to produce, but our medical school producing doctors is not going to solve the problem alone. We're going to have to rely on nurse practitioners, other alternative caregivers. We're going to have to rely on technology and new aspects of technology to reach these communities. And I'll conclude by saying that probably the best thing we could do for people who live in rural communities is keep them from getting sick in the first place, right? And so we have to have those public health people involved in helping them to not smoke, helping us lose weight, helping us keep our blood sugars under control, dealing with youth poverty. She mentioned that a couple of times because one of the highest contributors to health problems in young people is really an economic one. So those are issues that we have to help these rural communities overcome. And if we can do that, it makes getting a physician in your community sort of a cherry on top. We got to build something, a foundation underneath that. And we've, in my opinion, ignored some of those issues.
Oh, thank you. You make a really great point. And I think as far as the nurses are concerned, just speaking to the workforce shortage, we, as a health district, looking at the organization, really can't compete with the hospital system that's offering, you know, $20,000 and $30,000 bonuses. What we can offer is, in the 8 months that I've been administrator, we have a 4-day work week, or we offer like hybrid work situations where maybe you do a little bit on site and maybe you can do a little bit remotely. And we also have a lot of programs where those folks who we identify with, you know, with my organization, as we're all service oriented, right? We do staff surveys, we talk to one another, and we figure out that, hey, if that's one of our core values, then what kind of programs do we want to go after? What kind of grants do we want to seek to make sure that we can help, you know, your papa, your mima, your cousins, those folks that live right there in your community. There are a lot of folks who are from these communities who want to stay here, who want to be here, but they also have to be able to take care of their families as well. And so, you know, incentives, whether it be from the federal government or the state, in, you know, recruiting people, retaining them, keeping them here, whether it be helping them pay off their student loans, or maybe it is a sign-on bonus. And just to speak to you, when you were talking about the the couples, I was in Austin. So let me go back up a little bit, excuse me. I worked for the health district in Lufkin back in 2015. I worked on a program there with the National WIC Association, and it was about policy, systems, and environmental changes. And I learned a whole lot about WIC, the Women, Infants, and Children program. I learned a whole lot about those policies and those systems and what things we needed to put in place to make the healthy choice the easy choice. What came out of that program was, we talk about food insecurity. The East Texas Food Bank comes through there. We have a lot of food pantries and a lot of food banks, but where were we getting, fresh fruits and vegetables from? It took a collaboration. We sat down with the East Texas Food Bank and we talked to them about what our needs were, what kind of things we were seeing. And the outcome was, well, hey, we're getting ready to reroute our distribution sites, and maybe we can add that to it. We actually have a fresh produce truck that can come by and it will just be fresh produce. And it was just a conversation. It was just, hey, this is what we're seeing and this is what we need, and we made it happen. And so to this day, fast forward 8-9 years, and they're still doing that. And so we still have that there in our community. But further, I just believe that with the couples coming back to a rural area, yes, I was in Austin for 2 years after leaving the health district and now coming back, working for the central office in Austin. And my husband works for the hospital. He works in surgery. And so to get us both to come back, it was those connections that we made previously. Those people that we knew, the people that knew the work that we had done before. And so making that connection made it really easy to get my husband to be like, sure, I'll leave my golf buddies here in Austin and come back to Lufkin to be by your side. So, yeah.
I really think what we're talking about is just our collaborative efforts. We all got, when we become friends and we talk to each other and kind of what's available in the community, you can really empower your patients. We started in our FQHC, see a ton of diabetics. And part of that has related to economics, again, like we've talked about, because you just can't afford to buy the fresh fruits and the vegetables that you ought to be eating. So they're eating, things that they can get that there's plenty of that they can survive with. And so we captured a diabetic educator, and we watch those hemoglobin A1Cs. They routinely see our educator, and we talk about food and food insecurities if they have those issues, and have actually a medical student kind of took it on to work in that arena with us, and is building a project that she's going to present as part of her work in her 4th year of medical school about how to help these people with food insecurities. So I think the important thing is that we know what's available in the community and how to do that. And there was a time, I think, that we wouldn't talk about the social issues. And I think we've passed that, thank God. We've begun to deal with the issues that, hey, if you've got trouble with a roof over your head and can't afford to pay your electric bill and you can't afford to buy food, and you see that kid with an earache and you write a prescription, that patient can't get it. That's not okay anymore. We have to address that. And then people are getting care, which is what they should be getting. And that doesn't cost near as much as open heart surgery, as neurosurgery. And no offense to my neurosurgical friends, but they're expensive. They ain't cheap. But anyway, working together, collaborating, it's what it's all about. Resources from public health, from educational institutions, from the doc on the ground, the nurse on the ground, that caregiver in the home. Listen to them, empower them. That's what we got to do.
Well, and so I know with each of your respective positions, you've worked beyond just your specific communities. You have organizations that they care for the surrounding communities, the people in counties that don't have hospitals or barely have clinics. Can you talk to me about how you reach those people and what sort of challenges they're facing in getting that help that they need?
So how we reach our clients. So the health district, as I'm told, and just the history of it, was really formed to help meet the need, meet folks' need there in Angelina County. because we do have 2 hospitals there. And our public health district is kind of a unicorn in Texas because we have a primary care clinic within. So, yes, we do immunizations. Yes, we do chronic disease education. We do public health emergency preparedness, but we got a clinic in the center. And so we have, that clinic is actually run by our health authority, our medical director, Dr. Kendrell Tucker. And then the providers within the clinic are nurse practitioners and PAs. And the way that we reach those folks in our community within that clinic is a lot of, I think, word of mouth. We're always trying to figure out, well, what do we do on the website? What do we do in social media? How do we get folks to interact a little bit more? It's really just like your nurse is at the grocery store or at Walmart one evening, and they're like, oh, hey, I need to go and get my checkup, or I know it's been a while, but I really need to get back into the clinic to see you guys. And so once again, it's that personal connection. That's what makes, rural health, or really our rural communities unique, is we have that, whereas maybe in the big city, here and there, sometimes you might, but in a rural area, it matters so much more. Just what your church, thinks about you, the groups that you influence that you don't even realize, it carries a lot of weight. And so I think a lot of what we do is just making sure our workforce too is also diverse. And so we have a lot of Spanish speakers. We have a lot of folks who are, young or old. We have folks there who with 20, 30 years of experience. And then we have folks who are coming out of school. And so all of that, we use that to just make our organization a lot stronger to be able to carry out a lot of the programs that we have.
I think the biggest challenge is just getting those people to realize that we're available. There's a lot of frustration when the doc is not right next door. I mean, and I think that's really hard for people to get their head around. We started this federally qualified health center because in Henderson County, I think probably, now if you look at the data, it's going to say about 18% don't have any health insurance at all. And but if you look at the reality, the health insurance some of them have is pretty poor. And Medicaid pays me to see a kid with an earache $28. Now, I can't pay any bills with that. Okay, I can't even pay my bills with that, much less anything for a doctor to have. There's been no change in Medicaid payment since 1997. So we're getting the same pay. None of that's changed for physicians. There has been some other change that in this last legislative session, they expanded availability for pregnant women, and pregnant women can now stay on for a full year after they deliver, which is a godsend. That's where we've seen a lot of deaths in that pregnancy arena. So we've made some progress, and we're getting paid a little better in the arena of child care or of child health care. But if you look, Texas still leads the nation. We lead the nation in uninsured, period, and we lead the nation in uninsured children. And I don't know whether that bothers any of you guys, but it bothers me a lot. And having the federally qualified health center lets me take care of those kids no matter what they got, no matter how hard it is for them to get on Medicaid. We're able to take care of these kids, and it's just been great. I mean, in Henderson County, we started in May of 2020 with no patients. We now have almost 13,000 patients. Do you think there was a need? And 76% of our business is Medicaid or no pay. Now, in private practice, that's a prescription for disaster. You cannot make a living doing that. You cannot survive doing that. But you can in a federally qualified health center because you're paid a lot more, and you're paid directly by the federal government. The state has basically no dog in the hunt to talk about East Texas, okay? And so there's no payment from there. It all comes from the federal government. So having these things begin to plant, the legislature in its wisdom is now putting money back for incubator FQHCs, startup FQHCs. They put in the previous session, the one before the last, they put back $5 million. In this last session, they put back $40 million. To start our federally qualified health center has taken about $3.5 million to do it. And we've raised that from foundations. Murchison Foundation, East Texas Medical Foundation, and Ardent Healthcare Systems has helped us because we've been able to unload their emergency room. Emergency rooms in our areas went from 16% no pay down to 9% no pay because they could come to our clinic. And like Dr. Calhoun said, get treated before they get sick. Take care of their blood pressure so they don't have a stroke. So we're able to do some really good things in getting those things started. And by seed money with this, you're going to be able to take care of a lot of people. You multiply that by 100 clinics across the state, you're taking care of 1.3 million people. And the federal government to pay for it. And foundations to start it up. Because you cannot be a federally qualified health center until you're run like a federally qualified health center and are surveyed. And, you know, we don't do anything efficiently in government. I don't care whether it's state or federal. It's really hard to get it.
I'll answer your question a little differently.
Okay.
You know, I've been blessed for the last 22 years to be a university president. Universities, particularly your great universities, enjoy a tremendous amount of support, taxpayer support through our elected leadership and our legislature, providing us with funds, philanthropy, donors providing us with funds, different agencies getting involved with us, and I'm frequently asked, well, in plain language, what do universities do? You know, in plain language, what do we do? And the answer to that is we basically do two things. One, we discover new knowledge through our research. And two, we share knowledge with others, sometimes students, sometimes colleagues, sometimes the public in forums like this. You know, we share our knowledge. And what we wanted to do with the med school in particular, but really across all our health professions and even in business and engineering, is use that strength of the university to help meet the challenges confronting our communities. And clearly we have healthcare challenges in our communities.
Right.
So that's why we have the med school. That's why they're focused on rural communities. It's not just that we're going to produce, you know, an extra 40 doctors a year. It's going to be the fact that we're going to have researchers who are actively engaged in working with people like this, working with communities. We've already started it all through Northeast Texas to figure out how we can improve healthcare and improve the human condition across our region of the state, which unfortunately has poorer health statistics than the state, than Texas in general. Much poorer than people realized until some of that research was done and we were able to identify what we need to begin to address in improving healthcare services.
Absolutely. And to follow up on that, you know, Smith County in particular serves as an island sort of in this healthcare situation because a lot of their healthcare outcomes are significantly better. But it does look as though some of those things are trickling out into the other communities. What successes have you seen in, and I guess what struggles as well have you seen in expanding those resources to help the communities that are around yours?
Well, I think I first started down this path at the large-scale level back in 2015 when we worked with a group of researchers out of Rice University to put out a publication called Code Red, The Critical Condition of Healthcare in Texas. And it got a lot of play and a lot of, he remembers it. You remember Code Red?
I remember it, I do.
Yeah, and it was, you know, it's one of those highlights of my career to participate in that because there was a lot of healthcare reform going on at the federal level at that time, and we wanted to focus on Texas. Since then, Julie, I'm trying to remember the first time the UT Tyler report came out specifically on Northeast Texas. But we looked at all-cause mortality and that sort of thing, and we got some baseline statistics, excuse me. And that was repeated again in 21, and we saw an improvement in healthcare statistics in general across our entire region through the efforts of people like this, through the efforts of other people, but in part because we began to understand where we could focus to have the greatest impact in improving healthcare in our region. And so I don't want to see us lose momentum in identifying problems, honestly, and coming up with solutions that the community can live with and they feel comfortable with to help us continue the trend. It is a positive trend right now, and that's the good piece of news that's coming out of all this.
Yeah, I have to agree with that as well. In Angelina County, just as the health district, we've had the opportunity to have the health disparities grant funding and did a lot of research with that. And we've also had a lot of early childhood development funding that came down, and we got a lot of information from that as well. Really, really great partnerships in the community with that, from the Interagency Coalition to Stephen F. Austin State University, doing a lot of work with them. And some of the findings, that momentum he was just mentioning, is going to be so significant because we've now identified, there's what we think, right? We think we know this is the issue, but then there is having those listening sessions with the folks in the community and actually hearing from them, well, actually it's this. Actually, I want to get to work, but I don't have transportation to get there. Actually, I want to see my doctor, but I'm having struggles figuring out where I'm going to use my funding this month. Do I buy groceries or is that a tank of gas to get to the clinic? And the other issue is, the child care. There's a child care shortage. Actually, recently in writing one of the grants I just wrote, a lot of our households are single households. Probably close to 50% of the households in Angelina County are single parent households. So, just think about that. How are we using our resources? How are we going about getting folks those opportunities, those economic opportunities to be able to get back into the workforce, to be able to contribute to the economy, in our areas? They want to, but it's about those systems changing, those policies changing to be able to support that, to be able to sustain it. So I'm on my soapbox now. I can go on forever, but I'll go ahead. Yeah.
I agree with 100%. Those are things that have to be dealt with. I think one of the things that's really made a lot of difference in our area is the spirit of the two big hospitals. The ones that they've been cooperative and collaborative and working. I think it's much better than it used to be, and I think that's really good. They have, and of course, we're in the UT system. They have been amazing. They have been there when we needed them. They've come to our aid and our support, and have a Christus facility in our community as well. They've also been fabulous to work with. During a time when our UT got hacked, Christus was right there beside us to help. I think that kind of spirit has made us so much better, and I think that's part of that is part of what's going on with the med school. And is a tribute to this guy over here to my right. I mean, his grace and really collaborative spirit working together and empowering has just been really special. And he's going to be missed around here a bunch. But we know where to find him. We know where he lives.
I'm going to miss you too, buddy. and you only got about 2 or 3 years practicing medicine on me. You said 44, I'm about 41, so years.
But you'll never catch me.
But, when we talked yesterday, I do want to bring up one thing for a bit of a more extensive discussion, and that's mental health.
Right.
And, I got interested in the mental health subject because I was trying to run a hospital. And I see Mary Elizabeth out there, Christus, or whether it's UT Health. One of the big problems we had to try to deal with was the fact that we had people showing up in our emergency room with mental health problems. And, they just clog up the works. And it was difficult to try to find a place to get them where they could receive the appropriate care that they should be receiving and so forth. And so that was one of the priorities we tried to take up early on and begin to expand our mental health services. And when I came as president, we did 0 in the way of mental health services out of UT in this community. Now we're one of the largest providers of mental health services, and we're looking at opportunities to expand that even more and do more of that. We have a psychiatric residency training program with 24 psychiatric residents in it, physicians to learn to be psychiatrists, to stay here in East Texas and provide these psychiatric services. We have a psychology program. In our nursing school, we have a nurse practitioner program for psychiatric nurses. And if we can alleviate that problem, we'll go a long way in making things better. And let me just say this. You take a person who has a serious mental health problem, serious depression, schizophrenia, paranoia. They have a serious mental health problem, and then you give them a little diabetes. You whack 10 years off their life. You give them diabetes and a little hypertension and a mental health problem, you whack 20 years off their life expectancy. It piles on like that because, they may not take their medicines correctly or they get confused or whatever occurs. So getting a handle on mental health will have a tremendous impact on our physical health statistics in our region, and I don't want us to forget that.
I was going to say, I think it's really important what you're talking about, and I know the residency programs are all looking at how to integrate mental health into our teaching programs at a higher level. We're talking with a psychologist who is probably going to join our faculty just to help us integrate mental health care into family medicine. Because if you look at what's going to make a difference in rural areas, it's going to be those primary care entities, the pediatricians, the general internists, the family doctors, the OB-GYNs, and the general surgeons. That's the bread and butter of the rural community. And I was fortunate enough to be in a community that had a lot of those things. We didn't have an OB-GYN until about 20 years ago, but the family docs were all doing obstetrics. So it worked out pretty good for our community to have those services available and then tap into the surrounding counties because there's no obstetrics from Athens to Dallas. I mean, the only place you can get delivered is to Dallas or come to Athens. So we're seeing a ton of deliveries that are just surfacing because all of the other facilities have closed.
Well, and I think that opens us up for the good conversation about what can community stakeholders, what can our community leaders and our state leaders and even maybe our federal leaders, what can they do to help you guys solve these problems? What do they need to be looking at, and how can they take that next step?
I'm going to give that one to Doug.
I'll punt it back. Yeah, it's an enormous lift, and I think a lot of it has to do with education. I think that most of us have access to health care, and especially leadership. If you're involved in leadership of any kind, I got great health care. I mean, I really do. I have availability through my colleagues that care for me that I know what kind of doctor they are. And so I have that. And I think we just don't understand how challenging it is for people who don't have it. And you got to listen. You got to look around you, read about it, educate yourself. Because when you become aware that it makes a difference when you have a roof over your head, it makes a difference when you have food in the refrigerator, it makes a difference when you can care for your family, you can go to the doctor and see why you're bleeding from somewhere you shouldn't be bleeding from. When you can do those things, it just changes your world. And realize a big percentage of our people can't do it. And they're not people who are freeloaders. These are working poor. We have to have some additional hours in our clinics, and we need to have, because a lot of these families have one vehicle, and they can't come until after 5 o'clock, or they can't come until Saturday. So we got to have some other things, and I think we've got to listen to people who don't have, and be receptive to that, and figure out how do we help them. And I think a little bit of money from the legislature to help with federally qualified health centers is a good thing. And a little bit of expansion of care for women's care so that they're getting prenatal care, that they're getting care before and after. Those are things the state legislature can do and are doing. But healthcare is not a big priority for them. And that's not they just don't get it yet. But we're going to keep telling. It's like the Baptist preacher. You tell them, and then you tell them again, then you tell them what you told them. I mean, I've talked to these legislators a bunch about this. It can get real frustrating, but we have to continue to share the message. And it's not a complicated message. It's more about just caring about your neighbor. I mean, we heard the college president mention the good book. It certainly is, and it has a lot of good advice in it. And one of the big things it says, neighbor is yourself. You do a lot of that, you start fixing our healthcare problems.
I'm a public official. I'm in the executive branch of government. But I'm going to retire soon, so I guess I can say what I want. People out there are cringing. But I will make a general observation. It seems these days to me that we're so focused on our different opinions, our differences. We almost break everything down to our differences with one another, as opposed to looking at the things that we all agree upon. You know, we all want good health care. We all want healthy children. We all want these things. And Texas is a great state. And if we can put some of those differences aside and put the energy and the brains and so forth and the resources behind just the things we all pretty much agree upon, that would be a huge step in identifying the types of things that can be done, whether you're coming from a conservative state or a liberal state or a conservative community or a liberal community or a rural community or an urban community. You know, these are things that I think we all want. And yes, you may be this party or this other party or whatever, and you know, you're angry, but we're also all human beings, and we also are people that can get things done. And I will tell you, the way Dr. Egos are, and mine is just the same, we disagree in the hospital all the time. We fight about how the hospitals run. We disagree on what kind of care a patient receives. You'll never see that. We go in the corner and do it. Julie will say that, yeah, that surgeon wanted it. So, and we do it all the time, but there's one thing that holds us together. We all want to do what's best for the patient. And we put our differences aside, and we get it done.
Absolutely. Christina, is there anything you wanted to add to that?
It's hard to follow up. That's really great. I mean, I had several things, and, you know, we're talking about the mental health piece too, just what we're doing. I guess I want to tie it back to the collaboration and the strengths of the rural area. We can talk all day about our challenges and kind of being a dead horse at some point, but really there are so many strengths in the rural area as well. We have the opportunity to talk to folks in our churches, in our communities, at our schools, and we get to partner with organizations that are doing the work on the ground. As far as mental health services are concerned, at Angelina College, junior college there in Lufkin, we have a public health resource center. We have a direct line of services to mental health support for students who present to that clinic. I don't like to call it a clinic, but to that resource center. And we can get them in there, right? And get them the help that they need, the support that they need. Having that partnership with the Burke Center has been extremely vital, extremely helpful to be able to do some of that great work there. And the incentive, what can the state do? What can our legislators do? Really, I'm really big about like meeting people where they are, and then also just planning with and not for, or doing things with, not for. We are a strong community. We know what it is that we need. We know what we have to do. But if our state support and our federal supporters can come around us and continue to fund the innovative things that we're doing, whether it's a mobile clinic that we take out to Zavala because folks can't make it into the health clinic, whether it's, you know, helping to pay off the student loans of a rising star in our community who wants to be a nurse practitioner or a doctor and wants to stay where they're at. These are things that we can do, and we need the state and the federal government to be able to support that funding to be able to sustain those things. And so I think that with that being said, you know, all of those things working together and the collaborations will really help and the things that we're already doing here in our community.
Absolutely. Thank you guys so much. I think it's time to open up for questions.
And so for those who are gathered here in person, we have 2 mics. If you'd like to line up and ask questions. We have several questions that have already come in online, 2 that are related to workforce issues, and so I'll ask both of them for your response. First question is, how would early career pathways programs in high schools like career and technology education impact recruitment and retention in rural communities in East Texas? Second question is, how would reskilling or upskilling programs, such as healthcare apprenticeships for allied health or peer support professions, strengthen and enhance the healthcare workforce?
I guess that since I'm the educator, he's an educator too, but different kind than me. Those early pathway programs are absolutely critical. It's not easy to get into a medical school. It's not easy to get in healthcare professionals in general, pharmacy school, any of those professional programs. If you come out of your school systems without exposure to things like algebra. I mean, I was very blessed to be able to go to very good schools where I grew up. And so I had calculus as a high school senior, not in college. I already had calculus when I went to college. Having that kind of academic exposure puts our young people in a much better position to pursue healthcare programs. And I think it's an obligation on our part as educators. Juan and the team here at TJC actually do a fantastic job of taking kids who have not had that kind of exposure and getting it to them in a short period of time so that they can transfer to us at a higher level. But if we can get more of that done in our high schools and so forth, it will be helpful. We're trying to assist school districts in doing that. TJC has dual credit programs lined up with our high schools in our communities here. So those kids can actually get TJC credits and get that calculus, whatever, at an early stage, the algebra and so forth, to make them competitive to compete to get into these professional programs and stay in the communities to practice when they grow up.
I was just going to say, I think it's important that as a practicing physician in the community that you embrace that opportunity to teach. I've been emailing back and forth with a 14-year-old. He wants to come and talk with me and interview me and maybe even follow me around and see a patient or two, if the patients are okay with that. And I found patients are excited about having somebody who might be interested in learning about healthcare coming with me to see patients. Had the privilege of attending a graduation for about a year ago now of a young lady who finished medical school that I delivered. And I get a chill every time I say that. I mean, and I had lunch with her this week, and she is so smart. I mean, it was just amazing. And she trailed me around when she was a senior. And I think doctors who are out there in small communities is where it happens. We know all these people. I know that whole family. I knew great-grandma, grandpa, all of them, took care of them, loved on them. And so I got to love on her. And it's just been so much fun. She come to talk to me about a fellowship. She's thinking about, she's training, by the way, getting her training same place I got my training. I mean, it makes a difference if you just engage them. Love on them a little bit, spend a little time. Doesn't slow you down a bit. You still get all your work done and makes your day a whole lot better. So I think that we as practicing physicians need to embrace those students so they'll hang around in small towns, and we can do it because we know most of them.
Encouraging those gathered here, you're welcome to ask your questions. We have a couple of mics here if you have them. This person raises what I imagine to be a challenge in many rural communities, and that's transportation insecurity. This person says, in my 30-plus years working in rehab in Tyler, I frequently heard patients and families with transportation insecurity. Our current system with the GO bus and Tyler Transit are limited in where they go. What do you see as the best way to address this, to bring people to Tyler when needed without breaking their bank? And I guess I'd add to that, both in response to Tyler, but also how other communities can respond to that issue.
Well, in our community, we use the Go Bus a lot. And a Go Bus is transportation provided for seniors and people who are ill. And they use that quite a bit, has a route, and they use it a lot. But in federally qualified health centers, we also have to have contracts with transportation entities. But now you got to remember, there are not a whole lot of cabs in Athens, Texas, okay? Just trust me, you can't stop on the corner. It's not New York City, you know, and flag down a yellow. You know, it's just not going to happen. So, but there are cabs in our community, and we have a contract with them, and we can go get the patient, bring them back to the office. We can take the patient home from the office. And then I've found, too, that if we can get families engaged, then a lot of times we get easier transportation. But that is a true challenge, and trying to get people to talk to you about that. I think a lot of patients are a little embarrassed. I don't have a vehicle. I don't have access to travel. You know, I mean, it's hard to say I don't have, you know, or I can't do. And but you got to be sure they know that's available. Our biggest challenge is getting people, they don't make their appointment. In my private practice, I had 2% no-show. In our current practice, we have about 18% no-show. And that's just because a lot of them can't get there. So we try to communicate with how can we get you to your appointment? How can we make those things happen? So find out what's available in your community and lean into it.
I appreciate it. My name is Randy Dum. I happen to be the mayor in Quitman. And we have been looking at a project dealing with mental health. My mother suffered from dementia and passed 12 years ago. We've all probably touched that. There's no place that really taught caregivers what to do or what to expect next. And I hear what y'all are saying about training people and get it. We need masses trained. Would a facility possibly with the opportunity to work with patients that are suffering from that their loved ones allowed them to be in a living lab environment to where CTE students could witness that. You could have your first responders, your doctors, your nurses, and anyone that wants to come back and, you know, and to participate to learn that. Would that be, to me, that would be a big impact. I'm just curious what y'all would see in something like that.
Well, it takes a village to raise a doctor. So I think we're always open to identifying opportunities where we can work with community groups and community organizations to expose our students and to assist. And we know what they're trying to get going up there in Quitman, and we're keeping a close eye on that and appreciate it.
To just finish up a little bit, we got federal funding.
Mm-hmm.
Texas needed to match the funding to get it. It was $6 million waiting on us. Texas Legislature, it fell off the last 30 minutes. I can appreciate your frustration. But this is something that your respite care, your daycare, your churches that could participate, in my opinion, that's what we all need to be doing. We do work together. We have no conflicts about which side we support politically. We're a community that wants to do that has worked 3 years, nearly 4 years on this project with a lot of input. We have a consultant out of Boston that wrote the book about letting people live. And that's what we would like to see. My mom, instead of being medicated in a wheelchair and like she's asleep, we would have loved to have had the fact that she could have still lived to her extent. And that's what we want to learn and teach in that facility. So I appreciate the time, but thank you, folks.
I think as a way to close the program today, we focused understandably a lot of the conversation on what's going on in Tyler and in this region. But there's folks who are joining us from all around the state in communities that may be struggling with a number of things that we talked about. Without understanding the work is deeply complex. What are those kind of first steps in terms of the spirit in which a community comes together and is able to prioritize? What are those words of encouragement you have for those communities who are listening today and think about what those critical first steps are?
I guess what immediately comes to mind is, yes, in general, and we discussed some of them today, there are approaches that have statewide implications. But I think it's important that we not forget how diverse a state we have in Texas. And what works in Northeast Texas may not work on the Rio Grande Valley for a whole host of reasons. You know, what works in Dallas might not work in Houston. You know, they're just these cultural and historical differences that are in place with respect to how you're going to approach these challenges. A good friend of mine is the president of UT Permian Basin. That university is doing all it can with its health programs to try to incorporate their health programs dealing with that population where issues like, you know, this oil production and workers are coming in and out, and, you know, there's no stable medical relationships firmly established and so forth, and how they meet the needs of that region. So as we work to identify solutions, I think it's important that we always remain flexible in how those solutions might be applied, given the geographic and cultural differences that exist in a wonderful state like Texas.
You know, that's an interesting area. And that group, the Family Medicine Residency Program, they're very innovative. And they're doing some things there that are very unique. And it's been supported by funding from major corporations, oil corporations that are really empowering that. And, you know, I think that's an area that would really help us. Just because you're not in the healthcare business doesn't mean you don't need to be in the healthcare business. Helping us understand how to empower patients and get them back to work and get them into things, and coming alongside us to develop new ideas and better ideas. We need leaders in oil production and you know, and shopping and other things that have knowledge and things we don't have, to come alongside us and help us figure out how to take better care of our people. It's all our problem. And you know, the diversity just makes things more fun. And I think Texas, that's why Texas got so much opportunity, because you know, we're all different, and different together is fabulous. Great stuff.
Yeah, and just to add to that, I would say it's just recognizing that the core values there. I was just talking to a colleague from Net Health here in the room today, and talking about opportunities across sectors. You know, if one lesson that we learned from the pandemic was that you are going to be working with folks that you never thought that you would be, it's still true today. And I think that across all the sectors, we all have the shared values. We want to take care of our communities. We want to do the right thing. We should leverage that. We should build on that, and we should use that to sustain us forward.
Okay.
I'm Dr. Bruce Hargrave, and I'm the chairman of the Health Services Committee of the Texas Silver-Haired Legislature in Austin. And one of our key emphasis in this legislative session is on urban health and rural health, because we're having all kinds of retraction in clinics and health services all over these rural areas. And we're trying to discover ways in which we can lead the legislature to make changes that will benefit those citizens in Texas, particularly those over 60 years of age, with accessibility to health care. So one of the questions that we have is, what kind of incentivizing could be done to practitioners, you know, doctors, or especially doctors, or nurse practitioners, or anything? They come out of school with large loans, many of them do. To pay those $1 million loans back or whatever, they really need to be more in a metropolitan setting to generate the patient load, to be able to generate the income to make that happen. Whereas in rural settings, that may not be that way. And I was wondering what you thought about incentivizing them, like if they did rural health care for 10 years or so many years, each year a tenth or
some percentage of their loan could be forgiven, or what other ideas you all might have about incentivizing these practitioners to be able to come to the rural areas. I was really particularly intrigued, Dr. Kern, with you saying you grew up in Northwest Arkansas. I grew up in Texarkana, and how so many practitioners never go beyond 200 miles of where they were trained, and depending on where they came from depends a lot on, or has an impact on where they may practice. So I was just curious about your ideas about incentivizing practitioners for urban and rural health.
Well, the biggest problem we have, especially with those of us who either don't comb our hair or have silver hair, the biggest challenge right now is the way Medicare is managing things. I mean, you're seeing a decrease in payment this year of about 6-7% in Medicare, and for physicians, and I know we're a group of people who are fairly well paid, but trust me, you don't get paid anything for a long time. My cousin said, I don't know about you, Doug, you were the first one of the Kern boys to start school and the last one to finish. Well, there's a good reason for that. I went to school for 12, 14 years before I actually made any money and was able to pay bills, and then I had to pay a lot of it back. I was fortunate my folks helped me a lot, or I would have had a bigger debt. But I think you can't keep cutting Medicare payment and expect physicians to continue to expand the Medicare population in their practice, because they have light bills to pay, they have employees to pay, they have all that. So we're going to have to address that. And you have to understand, most of my payment from Blue Cross Blue Shield, United Healthcare, and everybody else is mark to Medicare. So if you cut Medicare 6-7%, you just cut Blue Cross and Blue Shield 6-7% and United Healthcare 6-7%. Now, the reality is every physicians trying to herd a bunch of docs. I spent a year as president of Texas Medical Association. It's like herding cats. It's just, they're all opinionated, as Dr. Calhoun said, but whenever we need each other, we'll all come to each other too. I mean, if you get trouble in the hospital and you call for help, I'm telling you, all the docs come to help you. And that's a real special thing. And, but I think the hard part right now is that there's got to be some fairness and some reasonableness to how physicians are going to be paid. Hospitals are fewer numbers, a lot more power, a lot more cohesiveness, so they can really leverage how payment occurs. Physicians have a lot of trouble in figuring out how to do that. And hear me clearly, it's not about the money, but it is about the money. I mean, you got to have enough to pay the bills anyway. And in small towns, like in rural communities, most of it is Medicare. I mean, average age is at 50s, early 60s. And you go down to the border, it's all Medicaid, because average age down there is about 26. So you see this huge diversity, but both of those problems now are having trouble with payment. And that's going to have to be dealt with by legislators, not just state, but federal. And but I think educating that, look, it's a complex world, and we always say that about healthcare. And it is complex, but it's not complex. It's about the money, but it's not about the money. And you got to mix all that together and hopefully come up with some solutions that you can really implement that will stabilize physician payment and circumstances where doctors can practice in all kinds of environment and still survive.
So this will be our last question for the day.
Hello, my name is Delilah Reynoso, and I work for a very small grassroots organization called Texas Jail Project, where we're advocates for folks who are incarcerated, especially for individuals that have a mental illness or IDD or co-occurrence disorder. So my question is, why are we arresting individuals that are seeking services or care at a behavioral hospital? What can we do to change this practice that seems quite common?
Well, again, I have an interest in mental health and delivery of mental health services. And our legislature was generous to our university in helping support us expanding behavioral health services in this region. And it was in part, I believe, because we actually started that conversation not with legislators in Austin, but with local county judges. County judges don't want people with mental illness sitting in their jails, driving up the local taxpayer cost, when really they need to be put in an environment where they can get the mental health treatment they need and hopefully return as productive individuals within the society. So being a silver-haired legislator we had a little bit earlier or whatever, you all have a lot of influence. The local communities, those county judges were helpful in allowing us to sell the fact that we could provide value to the state by using a governmental entity like a public university to do more of that kind of thing. And so I guess my message is that, rally the folks in your community, work with your local elected officials. Those legislators do listen to their county judges and what their needs are and how to address them. I think you'll totally agree with that.
Oh, yeah.
Oh, yeah.
Yeah.
So,
all politics is local.
all politics is local. And so, get engaged. About the transportation issue, I was thinking about that too. I'm not a transportation expert. I don't know how you get them to us. Somebody brings them to me as the doctor, and we treat them and we send them back. And we have social workers and stuff to try to help us with that. But one thing I do know for sure, because my wife does it, if there are people in your local community who need a ride, and you belong to a Rotary Club or you belong to a church, and you can go and just sort of volunteer to give people who live in some of these rural communities a ride to Christus or a ride to UT, and get them to the doctor so that they can get their prescriptions refilled and taken care of. I'm not one to believe that we ought to dump everything on government. Sometimes we need to take care of one another. And so just keep that in mind.
And just to add to that, a story, just to back that up, we're talking about the county judge. In Angelina County, our county sheriff tapped into an opportunity to be able to have one of his officers be a mental health officer. So now, this just happened a few weeks ago, I had a client come in who was clearly having, an episode. So, my staff and I, we did everything that we could to protect the patient, to make sure that they were comfortable, but also trying to scramble and figure out, okay, what do we do? Although the Burke Center is just right next door, we know that there are processes in place, and we also don't want to call the police because we know that the client in the situation that they're in doesn't mean that they need to go to jail either. They weren't harming anyone. They were quiet, and we just needed to figure out what to do. And so I found out that we had that mental health officer who was available to come and speak with that client to make sure that they got the medications that they need, the support, the resources that they needed. It was a direct line, that relationship, to talk to that person and say, hey, we have an issue, can you come and help us out? And then they would be able to take care of it. And making sure, too, we can sleep at night, at the health district, knowing that we have that resource to be able to support our community and the folks that need that help.
I was just going to say, we have begun using a telemedicine device that it's kind of in a little bag, but it's just amazing. It's got fabulous cameras in it that you can see a patient. It has a stethoscope in it. I can listen to a heart. And so we've used that at the jail some. We've taken it down with the nurse, let her go, and I can tap right in and visit with the patient and say, okay, put the stethoscope on the chest, let me listen. And we're trying to get our residents into doing this because I want them, that's what they're going to do. They're going to do ultrasonography at the bedside. They're going to do telemedicine and see patients in between walking in a room and seeing the patients. They're going to see one on a monitor and visit with them that can't come in. That kid who's that we're seeing now, and we've just started doing a lot more of it, especially the children who have significant disability, cerebral palsy, that are at home that are so hard to bring to the office. We can see those kids on a regular basis now with telemedicine, changing the world. And I think we can do that with institutional medicine. I'm convinced we got to teach our residents how to do that. When I came to Athens 40 plus years ago, they had no doctor for the jail, so my partners and I covered the jail. We went down once a week and saw patients unless they had a crisis, and then we went for the crisis, But anyway, I'm just an old country doc, and there ain't much I ain't done.
He's an old country doc that got elected to be president of the Texas Medical Association. Every darn doctor in the state elected him to be our leader. And he's an old country doctor. Don't believe it.
Well, thank you three so much. I feel like this was a very good and lively conversation, and I'm so glad to have learned everything that I did. Thank you all again.
Thank you. Thank you.